Thank you for being here. Welcome to episode 2 of the iEco Dry Eye Patient Educational Series. I am so excited that you could join us tonight, and hopefully you were able to participate in episode 1 as well. Tonight, we are going to be talking about another incredibly important part of this whole dry eye conversation. We're going to be joined again, for those of you who are with us in episode 2, we have 3 outstanding dry eye minds with us. Dr. Perriman, Dr. Odell, and Dr. Breimer have returned to share their insights on the diagnostic process of dry eye. And we also have, yay, Dr. Amy Now. She's with us to present a phenomenal part of this, why we can do the things we can do now that we could never do even 5 years ago. And it's about the evolution of dry eye science. She's going to kick it off, and that's going to be followed with a panel discussion on what you as a dry eye patient can expect going through a dry eye evaluation in a dry eye clinic, and why we're spending so much time on this. It's so incredible what we know now about the differences in causes and symptoms that we reviewed in the first episode, and how that translates into making sure that through proper diagnosis we can kind of drill down and then finally get to a treatment plan that is exactly what you need as a dry eye patient. So I'm going to turn this over to Dr. Now, who, by the way, if any of you, I know we've got a lot of her fans in the audience. For those of you who don't know who Dr. Now is one of my heroes also. She is a partner in Korb and Associates. And those of you who don't know who Dr. Korb is, Dr. Korb is now 40 years of his life invested in the research of dry eye. And she's been there side by side with him for decades, and is probably one of the most committed, if not the most committed person about finding how we can make sure dry eye patients have an improved quality of life. So she's right here with the other 3 dynamic, incredible panelists, and I'll just let them take it away because they're the ones that you really can learn from tonight. So thank you for being here. And Dr. Now, do you mind sharing with us now your presentation on the evolution and the science of dry eye?
Yes, thanks. Hi, everybody. It's really great to be able to speak with patients like this. I lecture a lot, but I rarely get to do a deep dive like this with patients who are in the exam room just because of time. So hopefully you'll find this a little bit interesting. And when Suzanne asked me to talk, I said, well, how do I want to talk? You know, what do I want to say? And I do want to ask, though, I don't have remote control. So if you guys could give that to me, that would be great. Okay. Right. Nope, I still don't have it. So I'm going to stop it, and then I'm going to just start it again. And I'm requesting it. I don't have it. Can you guys relinquish control, maybe, Suzanne?
Yeah, I'm taking it right now. I'm just going to advance it.
It wouldn't be a Zoom call without a little
a little real life in there.
Okay,
there we go.
All right. Okay, let's click there. I still don't have control. Let's see. Now I do. Okay. Okay, so what I wanted to talk about was what patients ask me all the time, which is, why didn't somebody tell me about this? And for those of you who aren't in the science field or the health field, I want to give you a little bit of background about the evolution of scientific progress and how slowly it goes, and that there's a temporal disconnect between these epiphanies or these revolutions in the science field and the cultural shifts that happen in clinics. Hundreds of millions of dollars have been spent to develop dry eye treatments, and there's so many more choices today than we used to have. It's incredible, our arsenal. But the problem is that many of our treatments are only partially successful. And science teaches us that your treatment's going to be compromised if you can't adequately define the problem. So definitions drive everything. They drive the framework for diagnosis, treatment, and scientific funding. And so these are really important, and I'm going to take you on an odyssey of the dry eye definitions that have occurred over the last 4 decades. Okay, so there are over 75 causes of dry eye, And this is like a big jigsaw puzzle. So when we do a case history, we have to think of all the possible reasons that someone might be having dry eye. And we have to put them all together. And sometimes there's more than one reason that a patient might have a dry eye. But for those of you who were in the first episode, it's important to know that the common things are common. And although there's 75 possible treatments or possible causes, there's not that many that happen all the time. So environment plays a big role. Anything that dries out your laundry is going to dry out your eyes. So low humidity, wind, heat, things like that. Lifestyle is a huge issue. We're all on the computer all the time now. That's a big issue. Poor diet, dehydration, sedentary lifestyle, use of makeup, elective surgery, sometimes not elective surgery. These things make a big contribution. And then, of course, there's aging changes, hormonal changes, autoimmune problems, eyelids get droopy. So all these things are the common causes. And so there's a lot of causes, but there's also a lot of treatments, over 20 categories of treatments, over 100 possibilities. And so the trick is to match all of the diagnoses with all of the treatments. And to be successful, those things have to dovetail. But the problem is that we're still failing in many cases to adequately treat dry eye. So we have to figure out why. And so now let's just take a step back from the nitty-gritty of how do you treat dry eye to why do we have the philosophies on dry eye that we do? How did doctors arrive at their diagnoses and their treatment plan? And it's biased by our definitions from the past and our current definitions. So we'll take a little journey through this. So back in 1995, the National Eye Institute came out with their first definition of dry eye. And back at that time, the only people who were thought to really have dry eye were postmenopausal women, essentially. And no one else really was thought to have dry eye. It was significant. And they came up with this definition, and they said, you know, dry eye is a disorder of tears. And the primary message was that there was some kind of a water deficiency, and that caused the damage. And so this led to doctors saying, I've got to replace the tears. I've got to use drops. And drops are the mainstay of treatment for years and years. Subsequently, and this is a little bit of a nod to what Suzanne said, is that actually there's a specific part of the tear film that causes a lot of dry eye, and that's the lipid, but they didn't know it. So it was all about aqueous replacement. And then they're going to fast forward a few years later, back to 2007, so 12 years later. And in the intervening decade, there was a lot of research, and the research was on osmolarity. The research was how a salty tear causes inflammation. So once there was a sufficient body of work, there was a consortium of the world's experts in dry eye, where they review the world's literature and they summarize it. And then as the capstone of that, they come up with a new definition. And they say, hey, it's a disease of the tears. Dry eye is still a problem of the tears. You have to treat osmolarity and inflammation. So the osmolarity and inflammation part were new and really important and reflective of the research that had been going on. And the focus is still on using drops, but now we start using steroids and maybe some longer-term anti-inflammatory clinical steps. We then go to 2011. And Dr. Korb has been working now for almost 3 decades on MGD, and he got a little bit of traction. Initially, he was kind of laughed out of meetings, but more and more people started to understand it. And there was another international workshop that was convened, and for the first time, Meibomian gland dysfunction was defined. And this showed that basically the glands get clogged. This stresses the tear film and causes symptoms and inflammation. This is the first time that the focus is away from the watery part of the tears, and the focus starts to be on lipid. And now there's some lipid eye drops that have come out, and it was just about a year before this workshop that the FDA approved the Meibographer and the lipid flow. So, you know, from 1980 to basically 2011, you couldn't really even diagnose MGD. Okay, now there's some more research that comes in. And now the next sort of leap is to talk about the inflammation that happens in the cornea. A lot of attention starts being paid to the corneal nerves. What's happening to them? They're becoming inflamed. And this is when the DUCE-2 convene. This is the current gold standard for dry eye. They talk about a nod to all the previous definitions, which is a loss of homeostasis of the tear film. You get instability, you get the osmolarity, the inflammation. But now the really, really critical part of this is that there's a neurosensory component, which is the corneal nerves are getting involved, and this causes some of this. Okay, so after kind of going through that series of steps, hopefully you can see that every 5 to 10 years, the definitions had to change. And they had to change because the paradigm was inadequate. And that's also why treatment went from just drops to maybe anti-inflammatories, and a little bit into kind of trying to fix lipid, but we're still missing lipid. But there's another thing, I kind of talked about Korb and how his lipid flow took 30 years. But another example, and this isn't everything, but on the top you've got the definitions. On the bottom down here, we have some of the things that happen in industry as a consequence and where those fit into the timeline. But if you think about what's going on with the cornea, 2017 is the first time that any of the definitions have included corneal inflammation. But it was in 2001 that there was really one of the first publications about using serum tears for corneal inflammation. So now here we go again. We've got a 2-decade span between what happened in research, a definition being created that includes that problem, and now it's just starting to get in the clinic. So when you get back to that original problem of why didn't my doctor know about this, it's because it takes a really, really long time. 10 years is a super short time for doctors to start doing something in clinic that they read about in the paper. Okay. So what's the next step? Treatment is still failing, and it means that there's something about the definition that isn't present. There's something that prevents you from taking all of those 75 reasons that you have dry eye and putting them together in a jigsaw puzzle that fits together. And so the one thing that is always absent in any of the definitions is the pivotal role of the eyelids. The eyelids are the defenders of the tear film. They spread the tear film and they protect the surface of the eye. So I think that if we have to find something that's missing in all of the definitions, it would be the eyelids. And Dr. Korb and myself and 10 other people have worked over the years to try to come up with another definition. This is just really for the purposes of lecturing and talking to people and making them understand about what they have to do to help their own dry eye issues. But dry eye is a term where it's a multifactorial condition, but at some level for the common forms of dry eye, the inability of the eyelid and the tear film system to protect the ocular surface. And then there are corneal sensory abnormalities that occur. And the upshot of this kind of a definition is that it talks about the role of the eyelids and how that has to be revolutionary because it implies that there's a dental model, that the eyelids can get dirty and diseased if you don't take care of them. And so you can't wait to treat. So if you look at this person all the way over on the right side, you know, they should never be allowed to get like that. Look at their eyelids, they're all inflamed. If you can treat that early, just like a dentist tries to prevent cavities and gum disease, I think it can have a really big impact on your own dry eye. And it's so simple, it's just that you have to take the time to do it. If you wind up letting an eye get too inflamed, then you have neurosensory issues, which are a big problem to deal with. And so I want to just show a couple of slides here just to illustrate how the eyelids can fail to do their job. So these are the kind of people where, you know, you're going to put them on Restasis or maybe serum drops or do lipoflows or IPLs, but they're still going to wind up having a problem because you have to address the lids. Up here, this lady has asymmetric eyes. This eye is always going to be a little bit drier on this side. Here's someone who has Graves' disease, where the eyes are open all the time. This man over here has some aging changes. No matter how hard he tries to blink, or no matter how many warm compresses he does, those lower lids can cause problems with protecting the surface of the eye. The Meibomian Glands are just going to clog up again. There's going to be inflammation there. Sometimes people have blepharoplasty, and sometimes it's too aggressive. So here's a woman who can just never close her eyes all the way down, even during the day. And then here's a woman who had blepharoplasty, but maybe she can close them during the day, but they're open all night. And then she always has about stress of the tumors. The eyelashes can go into the eye and cause problems with the cornea. And then you have that person who just has basically a dirty room. So as clinicians, we have to pay attention to what's going on with the eyelids and solve those problems. Or it's very hard to just expect a drop or anti-inflammatory to do the trick. Okay, so let me just take 2 slides and just talk about the importance of the corneal nerves, because they're so, so critical. We still don't understand the exact mechanisms of how corneal nerves become irritated, and we sure don't have great ways to quiet them down. But hypersensitive corneal nerves are probably more common than we realize. And one of the reasons we can't diagnose it so well is because there are no widely available clinical tests. You can get confocal microscopy, but that's a $200,000 instrument, and that's only going to be in big academic centers most of the time. And there's not a really great point of care test like Osmolarity or Mmp9, like we'll talk about a little bit later. But when the nerves get irritated, treatment is prolonged, and the pain of dry eye can be really difficult to control. To just sort of talk about that a little bit more, I want you to just conceive how this corneal nerve pain might evolve. So let's take an example where there's surgery or like LASIK, which doesn't always cause problems for sure, but in some patients it does. Cataract surgery, trauma, infections, and maybe you get a corneal ulcer or herpes, and you've had radiation. Those things can all damage the corneal nerve. They're a little bit less common than some other things that we subject our corneal nerves to. So, for example, you can imagine a 55-year-old woman who wears makeup, who uses a computer for 10 hours a day and uses artificial tears 5 or 6 times a day. Well, that person's going to have makeup that has formaldehyde derivatives in it, and maybe some heavy metals and some other chemicals. And those are on her eyes all day long. Not very many people wash that off very well. Then you're going to have salty tears because of the desiccating stress from using the computer. And then if you're using artificial tears with preservatives more than 4 times a day, that also contributes to, I think, a toxic tear film. So there are 7,000 corneal nerves per square millimeter in the cornea. And some of those are going to get irritated when you're bathed in all this toxicity over the course of decades. And initially, you might not have any symptoms, but eventually what happens is you become hypersensitive to stimuli that normally wouldn't bother you. And an example of this might be you're driving in your car and, you know, the person you're driving with puts on the heat. You're like, oh, my eyes, you know, you just want the heat to go off. Or you're walking on the beach and your eyes start tearing. Or you're in a smoky room and they start to burn. So peripheral sensitization phase occurs when things that normally shouldn't bother you start to make your eyes burn or wobble. And if that continues on, then what can happen is almost like a phantom limb kind of pain where you can restore the surface of the eye and it's fine, but it's almost like the pain is centralized in your head. But this is something that we feel is really, really important, and it's one of the reasons that patients may get treated, but they fail to improve. So I want to try to just bring everything kind of back to what would happen with an actual patient. And these are patients that we see, I'll see 2 new patients like this a day, and it illustrates how the current definitions drive our treatment. And it also illustrates how, if you pay attention to the eyelids and the dental model, that instead of reacting and treating dry eye, you can actually try to prevent it. So this is a person who comes in and they say, I can't wear my contact lenses as comfortably as I used to. I want a new kind of lens, and I use artificial tears. Right? And you look at this person and you do Meibography, 40% of the glands are gone. They have blepharitis, they have a little bit of rosacea, they're on the screen 10 hours a day. You do some other tests that we'll talk about later, where they've got inflammation in their eye by Mmp9, tears are salty. So this person is all of a sudden a big project. But anything that you do has to involve cleaning up the eyelids. This person basically has eyelid gingivitis, and it never should have been allowed to get to that point. So now you have to have the patient do home therapy. And there's all kinds of choices. There's many different things you can use here. I just threw a few out, but you have to do warm compresses. You have to clean the lids every day, or at least every other day. You probably should decrease their contact lens wear by 50% and get them out of multi-purpose solutions and put them in a daily disposable. They should have some kind of an eye drop to stop the desiccating stress, because their tears are going to evaporate too quickly for sure. And this person's on a computer for 10 hours a day. They need to wear moisture chamber glasses so that those corneal nerves won't be exposed to air all the time. But that's not going to be enough. This person needs in-office treatment. And one LipiFlow is not going to do the trick. I mean, that guy's been a lot of delayed maintenance there. So they may need 3 LipiFlows. They may need 6 to 8 IPL sessions over the course of a year to a year and a half. And then they're going to need steroids. They're going to calm down that lid. So steroid and antibiotic combination, and then you're going to try to have to calm down inflammation of the nerves. So you're going to get serum drops and Regenerize, and maybe some other anti-inflammatories, Xiidra, and Stasis. But now,
Dr. Now?
Yeah.
Can you move up a little bit, because it's a little hard to hear you, or can you get a little closer to your mic?
Yeah.
Thanks so much.
Okay.
Thank you.
So now this has become, a 2 to 3 year project, and the patient's going to have significant, thousands of dollars of out of pocket costs. And so if you can try to treat early and clean up the lids and prevent that from ever getting to that extent, then I think that will have a really big impact on the amount of money that we have to spend on that. Okay, so we kind of just have 2 slides left. What are common pitfalls? A real common pitfall for the doctor is not matching the diagnosis to the treatment correctly. It can be really overwhelming sometimes to do that. And many times we see that you try to treat one root cause. Maybe you're trying to go for MGD, but you fail to treat something else, like lifestyle issues or the fact that someone's got an autoimmune disease. So you have to treat many things simultaneously for many patients. Another pitfall is that you're too reactive. Maybe the patient's not really bothered. You see that there's something going on, and you talked about home therapy, but they don't want to do it. And you're like, maybe I'm not going to do anything else right now. But if you wait, it's like going to a dentist that says, you don't need to brush your teeth until you get a cavity. So we have to stop doing it. It's just not appropriate anymore. We also can't promise what a therapy cannot deliver. So we cannot say, hey, Xiidra is going to make you feel a lot better if the patient's staring at a screen all day long. It can't possibly work, because you're not treating the main cause, which is bad blinking and desiccating stress. The other thing on the patient side is that a lot of patients erroneously think that if they pay a lot of money for a treatment, that it's going to have an immediate effect. And that's not how it works with moderate disease. It takes time for tissues to heal. It takes a long time for the cornea to heal. It can take 2, 3, 5 years for people to feel better sometimes. And if you wait too long to initiate therapy, or you don't do your home therapy, for example, it becomes a really big and expensive project. The other thing is that patients often just undermine therapy by their lifestyle choices. And so if you're going to continue to use makeup and not wash it off, you overwear your contact lenses or don't clean them, you don't sleep well, you don't exercise, your diet's bad, you're dehydrated, all of these things, they can seem like little things, but if you take them all together, they really are detrimental and they undermine all the other effort that you're trying to make. And then on the last slide, just to talk about the evolution, the summary. So identifying the nature of dry eye is really a work in progress. And the definitions change because the science changes, but it's all a really, really slow process. So you have to be patient with the doctors. They have to digest a huge amount of material. And to be honest with you, as a clinician, I'm always very skeptical of anything new that comes out. So there's a new drop. Well, I'm going to not do anything with that drop until I see 3 or 4 peer-reviewed, well done studies on that. So I'm not going to just use my patients as an experiment. It takes time for all of that stuff to be published. So there is this temporal disconnect of a minimum of 10 years between what's happening on the basic science side and then the industry side and what happens. We all have to kind of work together to push the envelopes a little bit. But we think that the next evolutionary leap is going to be the pivotal role of the eyelids, and not just treating dry eye, but preventing the common forms of dry eye. And then again, trying to tackle the importance of corneal nerve health in dry eye.
Super.
Thank you.
Super. Thank you so much, Dr. Now. Boy, and that's a really wonderful overview. And you start to appreciate just how complex this dry eye is. And I guess I go back to, as a patient, and I am a dry eye patient, and everybody listening in the same, is that, so now what? Maybe you've been tolerating something and it all of a sudden is becoming too much of an annoyance, and you figure you have to do something because it's just not getting better, and you're signing up for a dry eye evaluation, or you're out there and you've gone through this. A lot of times people don't even know why they're doing what they're doing in an office, in any doctor setting. I'm playing patient. And so what we want to do for the rest of the episode is really walk through all the different tools available to doctors today. You might not have all of these done while you go through a dry eye evaluation, but really your journey as a patient, what to expect, and what are some of the things that might happen based on who you are and your physical condition and what your eyes are telling the doctor and what you're telling the doctor. So I want to start with our favorite part is filling out paperwork, right? We all love that. Not our favorite thing, but in the world of dry eye, it's critical. There's a lot of good stuff that comes out of these questionnaires. So Dr. Odell, do you mind maybe we're kicking this off with the panel to talk about what questionnaires a patient could expect and what the value is of those questionnaires?
Absolutely. And thanks again for having me back. This is a lot of fun to be with this group. And I like what Dr. Nell said, and have patience with your doctor, because sometimes this is an area where people do grow a little bit impatient with us. But one thing that I love about questionnaires, especially if I'm using a validated questionnaire, which is what I typically use in my practice, is that not only does it help me establish your baseline, so I know how bad your symptoms are, but as I start a treatment for you, I repeat my questionnaire and I use that kind of to help guide the path of your treatment. And so, yes, it sometimes does feel like you're filling out the same form every time you're in, but it really does give us very valuable information. And I'm sure that the others on this call would agree with that as well. One of the biggest things is kind of picking which questionnaire we want to use. And I'm going to actually jump back to this slide in a second, but you can see that there's a big list of validated questionnaires that are out there for doctors to choose from. Some of them that are based off of the science that Dr. Now was touching on, with TFOS dues too would include the dry eye questionnaire, DEQ-5, as well as the OSDI. Another one that, is very commonly used within the eye practices is called the SPEED. And that is one that I use quite a bit for my patients. And honestly, sometimes I personally like one piece of paper wasn't enough. I sometimes do combine questionnaires and give a combination approach when I'm, trying to figure out, what could be the reason for your symptoms. So I'll throw it to the panel just to see what your feeling is. I know that you're all utilizing a questionnaire with your patients. Is that varying from anything you see on the list right here?
I'll take the first crack at that. First of all, it's great to be here with all of you. Thank you so much. And I just love the patient clinician outreach effort. And thank you, Suzanne, for all you do to support it. To your question, Dr. Odell, we use a hybrid of a lot of these because I find each one gives me a slightly different piece of important information as I'm trying to sort out the different components of contributions for each individual dry sufferer's specific picture, all of their contributing factors. Specifically, we've added on a series of questions about photophobia. And we find that to be very helpful in helping to distinguish those more neurosensory compromised situations. And we added on a question about migraine headache disorder. There's an association with dry eye when it comes to that. Quality of sleep we've asked about, sensitivity to wind. So these things are, they give me little bits of other pieces of information that helps hone in what's really going on and what to recommend next.
And for me, as a screener, I use equipment as opposed to the survey. But when I have decided and receive from that result that they need to come back for dry eye eval, that's when I do extensive questionnaire. And it's not one of these, it's one that I created that talks a lot about their symptoms, their time of day, everything they've tried in the past, systemic issues that they have that might be contributing, as well as systemic medications that they have. And it is something that we ask them to grade each one of these symptoms on a scale of 1 to 10. And then every time that a patient comes back, in our chief complaint, I've got a scale where I can look at that number and they expect to come in and tell me, scale of 1 to 10, where are we? And that gives them perspective where if they're not sure how quickly they're getting better, I can go back to that original and say, well, we were at a 9 before, and that was 3 short months ago. We're doing well at a 4.
And also sometimes as you're gradually improving symptoms, it's a good way to gauge treatment success when we're having them, because sometimes when things are gradually improving, the patient might not realize that they are making headway with their treatments. So I find it helpful that way as well. But you can see, from this list that part of the reason why we use these questionnaires, like Dr. Perryman was saying, is because we're trying to pull out things that help us in our minds kind of narrow down this list as to what could be your contributing factor when it comes to dry eye, because helping us understand all of the factors that are kind of pointing toward you for your disease, because it's so very different from one person to the next, really helps us lay out a foundation for the treatment that's going to then be successful for not only symptom relief, but improvement of your tear quality and then in turn improvement of your vision. So the list is long, just like, was mentioned by Dr. Now previously, but questionnaires are often something you're going to see, whether it's, your initial exam or during a follow-up exam. So bear with us on the paper.
Yes, please. There's a method to the madness, and we need all that information.
Yeah.
I don't think it's important. It could be very important for us.
Yep. Thank you so much. And the next step, I guess, in the journey is now you've filled out all your paperwork and you're going to be called back, and there's going to be all this testing. And a lot of this stuff is even before you see the doctor. And there are a lot of tools available, as I've mentioned before. So we're going to take you through what those are and what they mean. Like what is this? What does it do? And why does it matter? And Dr. Breimer, do you mind kicking that one off?
Absolutely. Now, your doctor may not have every one of these, so don't be frustrated with that either. Some of this is overlap, and some of it we can determine by doing a thorough slit lamp examination where we're looking at the structures. But the more evidence, the more information we have, the better. And a lot of these enable us to have quantitative results where we can, again, measure your progress along the way. Ooh, too fast. So the first one is Mmp9 testing, and it's very simple to do this test. It's simply basically a swatch where we put it into that inferior cul-de-sac where the tears pool, and we, southern word for you, we sop up some tears, just like biscuits and gravy, but different. So we fill it up with the tears, we assemble the handheld activator kit, and then put it in the fluid, and within 10 minutes we have a result. Now, what is this telling us? It's telling us about a specific inflammatory marker in the tear film. So the normal range is between 3 and 40 nanograms per milliliter. And what this will do is a pink line will show up whenever it's more than that 40. So it lets us have a definitive test of, is there this inflammatory marker, is it present or is it not? Now, it is a little bit qualitative. So though we don't get a specific number, you can see that the red line is darker on this top image versus the lower one. What I found personally is that sometimes they were skating by me and I needed to get my light out and look under it to see if there was a faint little positive line. So if your doctor sees a red line here, this is going to indicate the need for potentially a steroid or some other anti-inflammatory course to go along with the dry eye treatment, which we do very commonly already. Osmolarity, this is also going to come about from a tear sample. This one's a little bit different. There's a tip on it, and we collect, it kind of pulls the tears in that way, and then we put it into its home base, and it gives us an actual number. So what this is telling us is basically how concentrated the tear film is. Now, if the tear film is very concentrated, and 300 milliosmoles per liter is our marker, but if it's very concentrated and it's above that 300 mark, then it means there's not enough water or oil to dilute these particles. So it's not an actual inflammatory test, but the reality is if you have dry eye and there's not enough water, not enough oil, the particles are very concentrated, it's hard to maintain that very long without having secondary inflammation. Now, what I've found is that even when someone has, quote, normal osmolarity, so that means they do have enough water, enough oil, there's so many other things that can be contributing. They can still have significant symptoms because they have other things going on, like blepharitis and the lid issues that were discussed earlier, allergies, and just inflammation in general. But what's nice about this is it gives you guys, you patients, a number where, again, here's our pre-treatment number, and as we move along, here's our progress that we're making. Topography, this is one of the devices, not this one specifically, but it's one of the tools that I use as my screener. Now, here's the reason. When you look at the rings on the right hand of the screen, they can be distorted like this for one of a couple reasons. If there's actual structural damage to the cornea, it can give us a distortion. But if we're focused out on the tear film, then basically the rings are reflected onto the tear film. So what this means is as you hold your eye open and you stare, then all of a sudden these rings are getting distorted. Well, guess what? That's exactly what's happening to your vision and your view when you're looking out. That's why you're clear right after the blink, and then you get blurry, blink, clear, blurry, blink, clear, and you're stuck in this cycle of fluctuating vision, and it's because the tear film is breaking up. So this gives us information on not just the tear film and its stability, but also if it's advanced to the point where it's causing structural issues to the actual cornea, it'll show us that as well. Meibography is the next thing I want to show you, and this is really important because years ago, we were not paying attention to the lids. We weren't paying attention to what's behind the lids or inside the lids, which is these Meibomian glands. Now, this is the source of the oil for your tear film. And the oil is critical in the tear film because it's what keeps it from evaporating too quickly. So when we talk about that clear, blurry, blink, clear, blurry, this blur is often a factor from the evaporation. So the more oil we have going to the tear film, the slower the evaporation, the better the vision, but also you don't have that burning effect that you have whenever there's exposure. So the way that I like to explain this is a one-way street. The oil can only go out. So if the oil's not going out and it's stagnant, it's clogged up, the body's not just going to keep making oil. It's going to start shutting that gland down. And that's what we see over time. Now, in this particular example, these are some pretty good looking glands. The lid is pretty full of glands. A lot of the patients, by the time they get to me, they do not have a lid that looks like this. You know, they might have 20% of that at best. So this influences how much oil is in the tear film, which again influences how stable the tears are and how stable the vision is. And when we start to see gland loss, that's when we know we've got to be way more aggressive and implement a higher level of treatment to stop this and open up the glands and get the flow going so that we don't have additional loss and are in a much tougher situation later trying to compensate for that. And here, this is a measurement of tear meniscus height. So I do this on every follow-up, actually. And I love it because it reminds me to have the conversation about water intake specifically. Now, while it may not be directly correlated and you drink a lot of water and we see more tear film, it still reminds me to have the conversation. And it's one more just bug in your ear of drink more water. Now, I do use this to let me know, all right, do we have quick evaporation causing, or is there something else we can do in the meantime while we're building that oil content? And this is a situation where I might put plugs in to slow down the drainage of these, the tear film so that more will stay on the eye. But it's a wonderful way to visualize the problem and then be able to, again, check the progress as we go along. And then it's really important to understand, again, the correlation between the tear film and the visual acuity. So many of you may be out there where you've gone in and you have spent thousands of dollars even on glasses, and you get a pair and maybe it works for a little bit, but then it's short-lived, and you go back and there's a problem and it's just been a nightmare for you. It may not be the glasses, the lenses, it may be your tear film and the dry eyes causing you to have, one, unreliable data. So when you're behind that machine and you're pressured with all the 1 and the 2s, you know, hard for you to answer because your vision's continually fluctuating. But also the tear film has power in it. It has refractive power, so it's responsible for some of that vision. And when it's missing and it's inconsistent, it's gonna affect your visual acuity. Another way to measure how much water there is, and oil, just volume in general, not specifically between the two, but tear volume, is with the Shermer test. You might have seen these, or you may in the future see this a couple different formats. One is this strip of paper. There's also another one that's a piece of thread, a red thread, and either one allows us to put it to a scale and see how much tear volume is being produced on a regular basis between blinks. So it's a quantitative measurement. This one is probably, if you have equipment as a physician, you're not going to use this as much as you are what we showed earlier in actually measuring the thickness of that tear volume. But this is something that's accessible to every single doctor out there, very inexpensive and easy measurement to make. And then something that's a little bit more advanced that I don't do on every single patient by any means, this is the Show test. And Sjogren's is a condition that affects the lacrimal gland, which is making your water in your tear film, but it also affects the salivary glands that's making the moisture in your mouth. So this patient may also have a lot of dental issues. And I have a lot of Sjogren's patients who, you know, they talk about between me and the dentist, they don't get anything done during the day because they're having to do so much work. But the times when I pull this out and I test the patient, it's when they walk in and there's unexplained sickness. So they might have joint pain or unexplained fatigue or something else going on that just has a big question mark beside it. I want to dig a little deeper and see what can I find out about their systemic inflammation. Because when I order this test, I'm going to order it with a couple other screener panels like an ANA, ENA, rheumatoid factor. And this is going to be a screener for autoimmune disease and rheumatoid arthritis, not just Sjogren's. Now, this specific Sjogren's test or show test, this is early markers. So it's been said that this can detect Sjogren's up to 6 years before the traditional markers will show it. So I do this, and I might repeat it again later. So just because you've had a Sjogren's test in the past doesn't mean that if it was negative once, it's always going to be negative. So if you're still having your dry eye complaints, and especially if your doctor is saying that it's inflammatory, you know, that's a reason to keep testing this and see if it pops up as time goes on. The other time that I personally will do a show test is when we've been, it's clearly an inflammatory dry eye. There's lots of redness, lots of lid swelling, things like that, and pain, but they're not responding to my anti-inflammatory treatments the way I expect them to. And that's another situation where I'll do this show test to see, is there something else we need to uncover here? So I gotta ask the rest of you, you know, what influences your decision to do this additional testing, show test specifically for your patients?
I'll go first. I'm careful to, well, as part of my extensive forms, as we just talked about, there's an extensive family history in there, and that's important. Like, I need to know if your family is a bit trigger happy from an immunologic perspective. That's going to increase my suspicion for Sjogren's. And then if I elicit anything on the review of systems about dry mouth, dry skin, cognitive fog, any neurologic problems, that's going to pique my suspicion for Sjogren's. And then if I see lissamine green staining on the conjunctiva, it's similar to that yellow strip that Dr. Breimer showed. That's the fluorescein strip, but there's another one, it's called lissamine green. And there was a paper, I think, written by Steve Flugfelder that showed that if there's heavy staining over the white parts of the eye with the lissamine green, that's highly correlative with Sjogren's syndrome. So if I see any of those things or hear any of those things in the history or in the intake forms, my index of suspicion goes up.
I agree. I think that paper maybe said about the temporal placement of the lissamine green staining also being important there. I look at that as well as sometimes if I have a high suspicion for Sjogren's because of the symptoms or the history, I will do Shermer testing, on those patients as well. Or, my tear meniscus height really helps to tune that in. I find the blood work to be helpful to me. I've actually still, though, found it to be a little bit, new when it comes to the rheumatologist and getting the diagnosis of Sjogren's. So, sometimes I won't have the traditional labs normal on that test, the SSA or the SSB lab, and some of the new proprietary markers are positive, and it's still a little bit of a push to find the right, really the right rheumatologist even to kind of pay attention to those labs.
That's so true.
Yeah, and I would say that, people do have Sjogren's. It's not as common as some of the other things, but many of those patients don't only have Sjogren's. They've got other causes, and you have to address the modifiable risk factors when you know that they have Sjogren's. I think those become really, really important to address.
Yeah. And then there's also, to your point, there's primary Sjogren's and secondary Sjogren's. You can have Sjogren's secondarily to other autoimmune diseases such as rheumatoid arthritis, lupus, or even ankylosing spondylitis, psoriasis even. So you can have secondary causes of that as well.
Thank you so much. I know we have a lot of Sjogren's patients in the audience, and they really appreciate hearing your insights. We're going to go into the third section here of the patient journey, and that is, Dr. Perriman, you started touching on it, but clearly you're going to be placed into the exam room now for the corneal evaluation. Do you want to take the audience through what that would look like on your end?
Sure. let's see, I think I need to request control and then we can go, right? Okay. I think I got it. Awesome. So this is where, you know, forgive the pun, this is where we bring it all together, right? We've been listening with our doctor ears, we've been listening with our doctor hearts, and now we need to look with our doctor eyes of what we see in each individual patient to hone everything in and really figure out what's going on. My goodness. Okay.
Yeah, if you click on
that is, okay, there we go. Somebody keeps calling me and I apologize. There we go. Gosh, all right.
Click, yeah,
don't you know I'm giving a webinar? Come on, no.
Yeah, there you go. Now you got it.
Okay, let's see if this will advance for me.
There we go.
So, Dr. Breimer showed those yellow strips, the bioglow strips, and that's really important for really highlight. I call this the highlighter, and it highlights where the mischief is on the ocular surface. And it tells you a lot, the pattern of it, the distribution of it. Like if there's a little band down low and tight by the lower lid, that can be from exposure from the lids not closing properly at night. If it's super diffuse like this on the right-hand side, that could be a very severe dry eye patient. And those areas of very, very bright green, like at about 11:30, that could be filamentary keratitis, which is found very, very late in dry eye disease. And they're quite painful. They remind me of a cheap Christmas sweater, like maybe with some of the, like, you know, the really cheesy, cheap Christmas sweaters. And when you rub on them, they pill. It's like that when you get so dry that it rubs those cells together. You get these little mucus and corneal epithelial cell strands, and every time you blink, it pulls on the corneal nerves. They're quite painful. So the distribution, the pattern, the density of the stains, all of these things are important clues to what's going on. Sometimes the cornea will look okay, but don't forget to look up underneath here, right at the top part. You can get a condition called superior limbic keratoconjunctivitis, and that's associated with thyroid problems, and sometimes lid friction syndrome. So it's other things to think about. And then this photograph is just showing the severity of the different staining patterns. And it's very interesting because you also see in between the blinking, there's a black area here. I'm not sure if my pointer is showing up, but in the middle picture on the top, there's a diffuse sort of bluish gray. I think it's supposed to be more green. I think there was a little issue in how this came about. But there's black areas and they look like little fingerlets there at the top. That's the area where the tears are not spreading properly, or they're breaking up very, very quickly. So that tells us a lot about the integrity of the tear film, which is protects your cornea. As Dr. Now was saying, we got to protect that cornea. And also your visual stability comes from here, as was talked about earlier. So just this distribution is quite telling for doctors. This one down here on the bottom right, that band low and tight on the lower cornea straight across, that can be from the lids not closing efficiently at night. And that becomes a great opportunity to protect it with some of those night sleeping masks, and IECO has several of them, and we use them a lot. They're fabulous for that. And it's such a simple test to look for this in clinic. We just take a humble little muscle light, turn the lights off in the room, and shine it right at the superior tarsus. And if you see light escaping in between the lids, that's an inefficient lid seal. And it responds beautifully to a vaulted night mask, and you can get those on IECO. And here's a patient of mine that this was in our phase 3 FDA studies for neural stimulation. We have all these amazing tools for addressing the neurosensory compromise. Here's one. This is called an iTear 100. It's from Olympic Ophthalmics, and it was just FDA approved this year. We were part of the FDA trials. And the top row shows the staining pattern of a patient with severe secondary Sjogren's, secondary rheumatoid arthritis, and those really dark green areas were filaments. In the middle two pictures, that was 2 weeks after starting the neurostimulation therapy, and then the bottom section is just 28 days after using the device just twice a day. So you can see improvement in the tear stability, in the staining, and certainly in our filaments. So again, back to that whole basic thing, that humble, simple bioglow strip, fluorescein impregnated strip is our friend in helping us figure out what's going on. Let's see here. The tear quality, you know, it's a tough thing to. This is my husband who keeps calling, and I don't know what's going on. Clearly, he doesn't know I'm in the middle of something. I'll talk to you soon, honey. I don't know what's going on there. Anyway, please forgive me. The tear quality is subjective, but we do have objective ways of measuring it with the non-invasive tear breakup time. I find that test on we have the Antares, which is similar to the keratograph that Dr. Breimer has pioneered some really cool reports for, but we use that to objectively quantify areas of unstable tear film. And I find it to be most helpful when things are really, really dry, like later stage disease. Dr.
Perriman?
Yes, ma'am.
Quick question. We just had one come in from the audience, and I think this is relevant right now. It says dry eye, and obviously the audience member has dry eye and being evaluated for cataract surgery. What can one do to make sure you get an accurate evaluation with dry eye issues?
Oh, wow. That's a great idea. A great question. So we know that several things contribute to what we call refractive surprises after cataract surgery. One is osmolarity that was talked about by Dr. Now early on. That's that teeny little salt sample of your tears that we take. And the higher the salt load, the more dry you are because there's less fresh tears coming in, right? So that's one thing. And we know that that can impact the topography that we use to base our surgical calculations on what power implant to give you. So osmolarity is one thing to look for. Mmp9 is not as well established as a marker, but we know that if there's a lot of inflammation in the tears and that Mmp9 level is very, very high, there's more likely to be epithelial irregularities, difficulties with your calculations, and also potentially issues with the corneal nerves. So there's a lot of reasons to check those simple things in addition to your normal regular cataract preoperative workup. There was even a paper that just got published like a month or two ago showing that medicated drop lifitegrast, commercially known as Xiidra, just in 28 days, statistically significant improvements in the ability to accurately predict the IOL calculations for the implant and the quality of your vision after the cataract surgery, as well as your aberrations. And we didn't talk about higher order aberrations, but it's how light spills and spreads, like rather than being sharp and clear. Higher order aberrations in general is just the funny things light can do in an optical system. And then lastly, the symptom score. So I think we're learning a lot more about how to prepare patients for cataract surgery, because you're about to put a wedding ring on the rest of your lifetime vision. It's good to prepare a little bit, in my humble opinion.
That's a great analogy. Very good. And then we're moving on to another area of evaluation that's been touched on several times tonight, and I think it deserves its own little section here. And it's one of the questions that we got a lot, or when we were talking about causes in the first episode about nighttime and how many culprits, there are about that can interrupt the quality of the tear film at night. And so I was going to ask Dr. Now if she could go over another step in the evaluation of the diagnosing the dry eye and what the causes are through eyelid evaluation. Dr. Now, maybe the panel as well.
Okay, yeah, feel free to just chime in, anyone. So one of the things, harkening back to the definitions, is it's our job to look at the eyelids and say, how are they not protecting the ocular surface? How can we leverage the eyelids to help us treat a patient? And it's not uncommon for me to send patients for eyelid surgery because you can see that structurally they're just not normal. And when they're abnormal enough that that they just can't do their job anymore, then it's time to have an oculoplastic consult. So droopy eyelids, these aren't such a bad thing, but I do notice that I don't know if you can see my marker, but in the corner of the lid, sometimes there's a lot of droopy skin here. When you're sleeping at night, the tears will start to kind of come out in this area. And if the tears are salty, you can get a lot of irritation and inflammation of that really thin skin. So when someone has droopy eyelids, I do look for that. And also, you know, can they just close properly? We're spying on you when we're giving you your interview. I'm always looking to see if you have a normal blink interval, or do you stare? Do you do a partial blink or a fluttery little blink? You know, how are you blinking? And do you need training, for example? Because without a normal blink, you can't reconstitute and spread the tear film. And some patients have blepharospasm. So, you know, you have someone with maybe some of those filaments that Dr. Perriman was talking about, or very light sensitive, and they just can't stop doing these really hard blinks. And that's another thing that you look for. Maybe a patient like that might need a scleral lens, for example, or Botox or something. Of course, we look at the Meibomian glands, and some doctors you go to might have a meibographer where they can take pictures and see if there's atrophy, but you have to express them and you have to see what's coming out. I mean, it should look like olive oil, you know, copious, beautiful olive oil coming out. Sometimes it looks like that cheese that's in a can, you know,
Oh, no.
squirt it, or just, you know, it's just like butter. And so the quality of what comes out is really important because it helps us understand, is this an infected gland? You know, do we need to really get into antibiotics with this patient? And so, and some people have what's called obstructive MGD, where you push and it's scarred and, you know, nothing comes out of there. So this is another test that we do to look at the lids. And the lids can get really inflamed. So there was a paper that came out, I think it was in 2017, maybe 18, Pedram Hamra at Tufts, and he looked to see, you know, how much inflammation, how many of these cells called dendritic cells are in the eyelid, just from, you know, people who were symptomatic, but they didn't really have a lot of signs on the microscope. He found a lot of these little dendritic cells, all these inflammatory cells in the lid. So we pull them down and we look to see if they're red and what might be going on. There's something called the line of marks, and this is another reason that we use lissamine green staining. So the line of marks is kind of the junction between the wet part of the eye and the dry part of the eye. And the Meibomian glands are supposed to be kind of right in front of that line of marks. But when you have chronic lid inflammation, what happens is that line gets really irregular and it starts to move forward. And if you're a careful observer, you can see that the Meibomian glands that wind up essentially switching places with the line of marks are often really scarred. And then you know that it's almost impossible to open up those glands, because you can open up oil, but you can't open up a scar. Or maybe you might think about probing or things like that, but that line of marks gives us a sense of the chronicity of the condition, and it's an important part of lid inflammation. Dr. Perriman sort of already talked about this, but you know, if you sleep with your eyes open at night, it's so hard to make you feel better. I don't know if the group has found that as well, but it's a really simple test. I don't have to go over it again, but if you've got morning symptoms and you've got light leaking down, when we put that little transilluminator on there, there's a pretty good chance of sleeping with your eyes open. And we've done some studies on this, and we find that there's a correlation between the amount of gland atrophy and poor lid seal. So hopefully we'll be submitting that pretty soon for publication. And then this isn't really the lid, but it kind of is. There's something called chalasis. And the white part of the eye has 3 layers, and the outermost layer is called the conjunctiva, and it's a little bit like saran wrap. And sometimes it gets saggy, and that's a common finding in patients who have dry eye. Well, underneath the lid, there's supposed to be a reservoir for your tears. And if you blink all the way down, that watery part can kind of get drawn up from this reservoir. But if that reservoir is occupied by tissue, you don't have those reserves. And the other thing that happens is over on the left, you can see that picture, is that that loose skin bunches up right against the lid margin. and it gets dragged around. And so people think that they've got a foreign body in their eye all the time, and it bothers them. But a lot of what they're feeling is just that tissue kind of dragging around. And sometimes steroids help that, but we do send people to have surgery on that, especially if they have scleral lenses and it bunches up around the edge of the scleral lens. That can be problematic. So that is an eye problem, but it affects the position affects the lids. And then there's things like we talked about not sleeping with your eyes all the way closed. Some people have floppy eyelids. So if you pull their eyelids up like that and they're really, really stretchy, there's a hard time closing them properly. They rub on the eye the wrong way. Sometimes you just have to have surgery to tighten those up. And if you have a CPAP, you can wind up getting air going into the eye. People who have sleep apnea tend to have really floppy eyelids. And in fact, I diagnose people with sleep apnea all the time just by pulling on their lids. And I'll say, yeah, do you have sleep apnea? Do you snore? Like, how do you know? It's your eyelids. So anyway, the eyelids are really, they're just, you have to take a look at them. And these are some of the things that we examine in the chair when you're with us. I think this is one last thing. I'm not sure why we have, well, here we have a blepharoplasty. Really, I send so many people for eyelid surgery. I'm a real advocate of it. I think you just have to tell the plastic surgeon if someone does have a pre-existing dry eye so they know not to be too aggressive about it. And then these two things, the cataract and the LASIK, I think these aren't the eyelids, but they're more about sort of possible causes for corneal neuropathy. But, I don't know, Dr. Perriman, I don't know if you do surgery or any of you other guys, when you send people for surgery, I always try to clean the eye up really well so that the surgeon doesn't have to contend with all of that stuff. I mean, do you guys do that also?
Yep, absolutely. And I think that the question that was asked about how do you prepare the eye for surgery was very, good for a patient to be thinking like that. I think that a pre-surgical evaluation is very much part of what I'm doing because I want to give the surgeon the very optimal, ocular surface. The lids harbor a lot of bacteria, so I want to make sure that they're completely clean before you're doing any surgery at all. One other test that I do sometimes to evaluate the lid, and you might have said it, and I'm sorry if I missed it, but is the snap test where you actually pull down and look to see how quickly the bottom eyelid will snap back up. Sometimes I've had patients that doesn't actually reset until they blink. I'll pull it down with a cotton tip or a Q-tip, and then it just kind of hangs down here until they blink, and then it resets it. And those patients, even though I'm working to try to rehab the Meibomian glands and what's coming out, if you don't have the muscle tonicity there to express the gland, it's really hard. So once I do pass those patients to oculoplastics, the oculoplastic surgeon, I get much better success with the treatment outcomes.
Super. And I know, Dr. Perriman, you're still in practice there, had to move out of one office or one room to another. But you had some comments you were going to make about CCH.
Yes, so CCH is very interesting. I think it partly is from elevated MMP9. So there's this little collagen fiber that helps to hold tenons, which is a deeper layer of the eye, to its loose connections to the conjunctiva. And as we have these inflammatory factors, it chews up those little bits of delicate little collagen, and that makes the conjunctival chalasis folds worse. Now, pre-surgery, there was, you can get a teeny bit of relief by, number one, in optimizing your goblet cell density. And we do that with our prescription medications, Restasis, Xiidra, and Cequa. But you can also get a little bit of shrinkage of those corrugated or those bumpy cardboard tissues and some of that friction by shrinking them just a little with something called Lumify and just the tiniest little drop. This work was presented at ASCRS about 2018 by Melissa Toyos. They were able to show on OCT a reduction in the height of the conjunctival folds, and we have some good photographs showing that as well. And that's in the pre-surgical arena. You can get some good management with optimizing your goblet cells so that you can reduce the friction factors, and then also shrinking those tissues just a little bit. Yeah.
Super. And then
Just
we're
real
gonna-
quick, Dr. Perryman, if I can ask you this. My mother-in-law actually had a lot of conjunctival cheilitis, and she actually was really good from a standpoint of dry eye, went into cataract surgery. It was a laser, laser cataract surgery. So I know that can sometimes make a CCH a little bit worse temporarily. But anyway, one of the advice I was given from another, maybe an oculoplastic surgeon, because I was actually thinking I was going to have to pass her for surgery, was about diet and sodium intake, which I thought was really interesting. And he really wanted her to cut out salt in her diet, not only, lubricating drops and doing all the things you were just saying, but I just wasn't sure if you've ever have recommended that with patients with that, or have you seen any success there?
Logic seems to me at all.
Yeah, I don't know. I never heard it either. That's why I thought I wanted to ask you. With time, she did get better. She was put on Restasis, like you said, just to try to optimize the goblet cell density. And then once we got to maybe 3 months post-operative, it seemed like she was actually having a lot of watering of her eyes because the conjunctival tissue was blocking her drainage of her tears. And so they were just coming down the middle. But anyway, always a challenge to treat your family.
Yeah,
All patients, you got to make them the happy.
Oh, and then I know Dr. Breimer had brought up earlier that in this process of what the patient experience, it kind of depends on what tools the practice has in play. And one thing that seems to be very common is the slit lamp exam that can really share, a lot of the story. So I thought maybe Dr. Breimer, you want to kick off your thoughts about how you use this in practice and the rest of the panel?
Sure. So no matter where you live and what doctor you go to, my hope is that every single time, they're looking at you with the slit lamp. So even if they have just the bare minimum, you basically get a degree and a slit lamp. So this is the basics. Now, what they do with it is going to vary from doctor to doctor. And we've talked about this a lot throughout the night and weaved in and out. But basically, my pattern is very, very consistent. So no matter whether you're there for a foreign body removal or glaucoma, macular degeneration, it doesn't matter. I am not going past the lids and the front of that eye without evaluating it. But you've got to be in that mindset to really pick up on the things we talked about throughout tonight. So I start out with having you look down, and I'm looking at the lashes to see, is there debris there? What kind of debris is it? Is it wet mucus? Is it dry flaky? Is it collarettes from a mite? And then I have you look straight, and I'm looking at the lower lid. Is it thick? Is it scalloped? Are there blood vessels there? Is it really pink and rolled? And then I'm going into the tear film, and I'm looking to see how much debris is there. And then I'm going to that conjunctiva to see, is there excess conjunctival tissue? Is it red? Then I'm going into the cornea to look at the clarity of that cornea. Now, once we put the dyes in, I'm going to look at those two pieces of tissue again and see, is it highlighted, like Dr. Perryman said? And then I'm going to come back to the lids and I'm going to clean it with a thin blade to see how much accumulation's there on the lid, and I'm going to squeeze it to see what's coming out of those glands, just like Dr. Now said. So that's my routine, because doesn't take long, but I want to spend a couple minutes on the very front of the eye before I get into the cornea and what's behind there, because that tells me everything that I need to know about the ocular surface health and the status. Now, the reality for me, though, is that if I'm the only one that sees it, it's not going to help you understand, or you to know and understand and believe of why I'm asking you to do something. And so then we might have an issue with compliance. I want you to do a treatment because you understand why and you believe that it's value, because then we're going to have continuity of that, and that's how we're going to get our outcomes. So what do you guys think? What's your go-to and your route to get there?
I think, Crystal, you said you have to look with the slit lamp. That's how you determine if there's interval change. There's the point of care testing, obviously, but at the end of the day, you have to take take a look and see what's going on the ocular surface and lids.
Great. There, and it seems like now, we haven't brought it up, but the trend certainly is because dry eye is so prevalent and there are so many causes, and we know that what we've talked about tonight really is looking at, we're gonna look for symptoms and signs and symptoms. And now there are so many practices really getting on board with, every single patient is important, and we're going to evaluate every single patient because they might not know if they have dry eye or not. They might not be symptomatic. And that brings us to another question that I think is of real interest to the audience. We've had it asked several times, which is, how do you diagnose that patient, where they have all the signs, but they have no symptoms? And maybe I'll ask Dr. Odell, do you want to pick this one up? Dr. O, did she drop off?
Yes, sorry, I had to
yeah.
find the mute. So this patient to me, is concerning because if they have all the signs of dry eye, but they're not feeling it, it goes back to what Dr. Now was saying, at the beginning of her talk, and how the definition of dry eye has changed. And now we are really focusing on the neurosensory role and how powerful the corneal nerves are. And so this patient isn't feeling that. That makes me more concerned that there's a corneal disorder that's not allowing them to do that. So this patient, I still would be diagnosing with dry eye disease, but my conversation might be a little bit different. Sometimes I will go to, the analogy of a patient that might know a little bit about diabetes and how that can affect your foot health, right? So a diabetic patient can sometimes develop an ulcer on the bottom of their foot and have no idea that they have that infection, and the much the same is what we're seeing with the cornea health in the patients that have a lot of the clinical findings without a lot of the symptoms.
And for me, this is a situation that goes back to that education piece and really showing the patient what's going on, and basically, correlating it to our experience. And one thing that I say is, dry eye is pretty much all I do anymore. And I see people, by the time they get to me, they're so advanced, but this didn't happen overnight. It happened long ago, and they would give anything to be in this chair where you're sitting and do something about it earlier. And I've seen such a difference in outcomes when we implement, year 1 instead of 2 and 2 instead of 4. But when you don't feel the pain, it makes it hard for you to either remember or buy into the fact that there really is an issue. So I think you really have to be shown that and judge your progress based on the clinical signs instead of your feelings. And for that reason, that's one reason why I don't start with the survey, is because for me, it's really about the structure. And then, I want to know the symptoms, but I don't want us to have a false sense that your diagnosis or your treatment or your need to do the treatment is based on how you feel, because it's not. It's based on protecting you from progressing and being in a situation down the road that could have been avoided.
I'd like to dovetail onto that. I think that's really great. There's back to that definition where there's neurosensory compromise. There was a paper presented at ARVO, I don't know, 6-7 years ago, where they were able to show the corneal nerve firing increases as osmolarity increases, to a certain point where they stop responding. And so once you get past that point where the cornea can respond and tell you that there's a pain problem, this frog that's come to a slow boil, when we slowly reverse all these factors and those corneal nerves start regaining the ability to tell you that there's a problem, that can be a sign that you're getting better. This is very, very important. I hear time and time again, oh, my eyes started bugging me, so I quit everything. It's like, missed opportunity. We're starting to regain that natural ability to sense, to regulate. And so when that happens, go back to your doc, look again at osmolarity and staining and all those things, because it could be that you're actually starting to regain physiologic control of all of those factors that we need for a healthy ocular surface. We call Dr. Daryl White, one of my friends in Ohio calls this the hill of sorrow, right? Of where that corneal nerve starts telling you there's a problem again, but keep climbing the hill of sorrow if you're ever going to get to Happy Valley. So just keep going and keep plugging away all those medications and wonderful strategies that your dry eye doctor set out for you.
I think that answers another question that just came in. It says, will eyelid surgery fix the pain I get in my eyes when I wake up? I had eyelid surgery when I was young to fix droopy eyelid over 10 years ago. And only last year I've been experiencing the pain. It's excruciating, as if somebody is poking glass or sharp objects in my eye or my eyes. And whenever that happens, my vision gets blurred. I get double vision in whichever eye gets the pain, sometimes both, and lasts over a few days. The general hospital said that I can go blind if I don't get surgery. I know we're not here to diagnose, but I'm wondering if the pain part of it is maybe part of that journey, that it's time to go back.
It sounds like it's maybe recurrent erosions too, you know, with very sharp pain like that. I mean, we can't diagnose it, but it sounds like there's maybe a little something else going on just besides dryness.
It's time to go to your doctor.
Yeah.
Well, my recommendation in that situation is the day that she wakes up with that pain, she needs to see them then so that they can put the dye in and see, do we have an abrasion that occurred spontaneously because that eye surface was so dry that the lid basically stuck to it and peeled it open. And then use the nighttime shelter. That Eye Seals 4.0 is phenomenal, and do that with ointment in that patient to help lubricate the surface and provide a buffer there where there's not going to be so much friction and sticking. So I would do that immediately, but when it does happen again, if it does, let the doctor see it in real time. Great advice.
Well, now this is a perfect segue too, because we're coming to the end of our episode 2, and really excited because you all, I know everybody's so eager to get straight to treatments. And I think that all this time we've spent on causes and symptoms and how to properly be diagnosed really does determine what that personal treatment plan is for you, for the patient. And that's going to be episode 3, December 1st, Tuesday night. Can't wait to have you join us. We're going to be talking about both in-office procedures that can be done based on your diagnosis, and also back to Dr. Now's comment, how critical it is that it's not just about what's the doctor's doing, filling the cavity, doing the root canal. It's what you're doing at home to ensure that you have the whole equation 360-degree covered. So I just can't thank you, doctors, enough for joining us tonight and for all of your hard work and contributions, decades of work in dry eye research and dry eye care, and really going the extra mile for these dry eye patients. And with that, I say good night, and I hope everybody has a wonderful evening. Thank you so much for joining us.